So our first speaker today is Dr. Bruce Barker. He received his Bachelor's of Science degree in biology from Grove City College in Grove City, Pennsylvania in 1993. Dr. Barker received his MD degree from Ohio State University in 1997. He completed his family medicine residency at St. Vincent Health Center in Erie, Pennsylvania, and is board certified in family medicine since the year 2000. He is also board certified in obesity medicine specialist as an obesity medicine specialist with the American Board of Obesity Medicine since 2010. Dr. Barker also spent 15 years working as a certified physician investigator, during which time he served as a principal investigator and founder of the Delaware Research Group, which conducted more than 60 major clinical trials, predominantly focused on the study of treatments for diabetes and obesity. In 2008, he founded Ohio Healthy Living, a multifaceted obesity medicine clinic, which is now part of the Ohio Health Weight Management System. Dr. Barker has served on several speaker bureaus, lecturing about various obesity treatments, including Concrave, Sandexa, and Zepbound. Dr. Barker has served on state and national committees focusing on education and advocacy for access to obesity care and treatment. So please join me in welcoming Dr. Barker.
So thank you for the introduction. So my topic today is going to be diabesity and behavior versus biology. So what we're going to try to tackle today is to take this complicated problem of diabetes and obesity and think about whether or not behavior plays the majority of the roles as to why this occurs in individuals. Is it just that I've made poor choices and I could have made better choices with my foodstuffs? And also my activity levels, or is there more of an issue with how my signaling works, and then does that drive some of the decision-making tree that I notice for myself? And so we're going to move ahead and look at, kind of talk a little bit about why we're seeing that we move less and eat more here in the United States. And so it's just some statistics. The average American consumes more than 3,600 calories in a day, which is a 24% increase from 1961, at which time we were averaging a little less than 2,900 calories a day. And there's lots of different thoughts as to why that is. We know that portion sizes have gone up across the United States over time. And so when you look at the size of portions you get at a meal, if you go out to eat nowadays, that the portion size has increased dramatically. We know that the type of foods that we eat have changed quite a bit over the years since, say, the 60s is used as an example, where processed foods and ultra-processed foods have become a more of a mainstay in the American diet and how we approach foodstuffs. We know that there are issues with activity levels. That activity has diminished here in the United States across the board. If you think about how life has changed since, say, the 60s or 70s versus now in regards to what you do in your normal daily lives, the activity levels have diminished a little bit. If you think about if you got out of bed in the morning in the 70s and you had to go get the news, how did you do it? You had to get dressed, you had to put on your slippers and your bathrobe, go out the door, go down the street, get your paper, go back, have a seat, and then you would read your paper while you watch drink your morning coffee. If you look at now, what do? You roll over in bed and you pull out your phone and you scroll and you check what's the feeds for today. If you think about how you would get a meal, in the 60s and 70s, you would have to either prepare the meal, go get the food, prepare the food, cook it, sit down and eat it as a family, or you would get in the car, try to get all the kids in the back seat of the station wagon without seat belts back then, and drive them to the local food store or restaurant, sit down, eat, and so forth. And so what do we do now? We get on our phones and we DoorDash. And so there's a change in expenditure that we're seeing across the country. Some of that has been influenced by the pandemic. We notice that people are staying home a little bit more. We notice that a lot of people are working from home more. There's not as much getting up and going to meetings. You don't have to get up and go to your meeting nowadays. You just flip on your Zoom or your Teams call. And so there's less and less expenditure that we're seeing across the country in regards to how we utilize fuel that's taken in. So according to research and one publication in Circulation, which is a cardiac journal, sitting at a desk burns about only 20 calories every 15 minutes on average. And so if you do the math, if you do the math, that's only about 640 calories per workday being burned, which isn't much compared to the intake that you're taking in based on the previous discussion. And so, so it becomes a challenge for people to kind of maintain that calories in, calories out balance that they need. And so we also know that we are we're noticing we're sweetening our beverages and sweetening our food in general. And so on the USDA in the most recent survey said on average the American adult consumes about an additional 17 teaspoons of added sugar per day as part of their dietary structure. So that's a lot of fuel that you're working with. So as I've alluded to, the reasons for the changes are complicated. So there's lots of socioeconomical changes that we've just alluded to. There are issues sometimes with knowledge base, where people just don't know what a portion is anymore because you go to the restaurant, they hand you a plate or a bowl, and you're like, I thought this was a portion, not 6 or 8, as it sometimes is. And then also what foods are made of and how they affect your nutrition and your signaling and how your body responds to those fuel stuffs is sometimes there's some gap in knowledge base and having that education for the populace. Certainly there's peer pressure. So we go to the family party and like, well, everybody else is having pizza. Why can't I have pizza? And so that becomes a challenge sometimes for making good food choices, even when you're aware of what you should be eating. There are issues with signaling, and we're going to talk a good bit about that today in regards to uncontrolled eating, in regards to hunger, like hunger cravings, where folks are constantly hungry, or if they eat a little bit and then a little bit later they're hungry again. What's up with that? Why do they just not stay full for longer periods of time? Some people have the challenges of emotional eating, and so that's when we're using food as a drug. And when you get a glucose spike from a foodstuff, if it's fast enough and high enough, you get a dopamine spike in your happy center, you get your happy on. And so sometimes people struggle with that and they chase the happy, and it's not really caloric-driven behavior. We see issues with sleep. We know that sleep is a challenge for a lot of us in America. And so we know that circadian rhythm disturbances for folks and chronic deprived sleep has some impact on eating behavior for individuals as well. Expenditures, we kind of already touched on that a little bit in regards to some issues with being able to get out and do things, the logistics of what life is like now in the US versus previously. There are individuals who have barriers for exercise and expenditure, where they have orthopedic issues or cardiovascular issues that make expenditure more difficult, and kind of how do I handle those components as you kind of move forward. And we know that a lot of medications we treat people with for other conditions can predispose individuals to weight gain. So the objective of today's talk is really to kind of make an argument for the biologic signaling of how the biologic signaling of glucose metabolism plays a role as a driver for feeding behavior in its relation to the obese state. And we're going to try to develop a high-level awareness of the pathophysiology of type 2 diabetes. Pathophysiology is a fancy way of saying broken biology. And so what do you understand about the broken biology that happens with the diabetic state, and how that interplays with what you see day in and day out in the way you handle yourself in certain activities and eating behaviors. We're going to look at developing awareness of diabesity as a disease and how it's an interplay between the obese state and the diabetic state. In that subset of individuals who deal with obesity kind of fall into a certain cohort of individuals that have certain physiologic changes and findings. We're going to see about how insulin resistance plays a role in that process for those two things, and how that signaling process drives some of the behaviors that some people see for themselves as they move forward. Hopefully you'll be able to appreciate the complexity of obesity as a disease versus just a behavioral pattern as we get to the end of this. And then I want to spend a little time on advocacy, talking about the awareness for weight bias and weight discrimination in the United States. So this is Webster's definition of diabesity. So it's obesity associated with diabetes, the state of being overweight or obese, and of having type 2 diabetes or one of the conditions such as insulin resistance that precedes it. And so if you take a page from the book of social media and so forth. If you think about Bradgelina, I know I'm dating myself now, but if you think of diabetes plus obesity, you get Diabesity, and that's how we got that name. So why does it matter? And so part of the reason it matters is that about 38 million Americans, according to the CDC, this is 2023 data, 38 million Americans have diabetes, and 1 in 5 of those individuals is not aware they have the disease process at this point. And so trying to make sure people are aware of this as a possibility and that there are components that need to be addressed so people can make sure they're getting the best control of their health. We know that diabetes uncontrolled leads to nasty stuff. And so we know that the traditional complications include problems with your kidneys functioning normally, and sometimes will lead to kidney failure. You can have problems with your eyes in regards to how the retinas work. It can lead to blindness. We can have problems with the nerve function. It increases your cardiovascular risks for heart attack, heart failure, stroke, peripheral arterial disease, and actually when you look at cardiovascular risk, type 2 diabetes diagnosis is equal to 1 heart attack in regards to cardiovascular risk. When we start to look at some of the newer emerging complications that we're starting to understand that, if you're diabetic, you're at higher risk for certain cancers. We know that infections are not as well handled by diabetics, and we saw that very clearly during the pandemic, that diabetics were at a higher risk for complications with COVID. We know that it increases your risk for liver disease, such as fatty liver disease, which can lead to cirrhosis of the liver in time. And we also see that it affects functionality and leads to functional disability through multiple different methods, cognitive disability, and then can put folks at risk for mood disorders. So this is just to give you an idea of the iceberg in regards to what leads to what. And so the intent is to kind of focus on that obesity precedes the diabetic state in a large percentage of cases. And so, this is a little bit older data, but at that particular time, a couple years ago, the number of folks who met obesity criteria was 115 million in the US. 88 million had the pre-diabetic diagnosis. 60 of those folks also had lipid abnormalities and metabolic syndrome diagnosis. And then 34.1 million of those folks met the diabetic diagnosis. And so what we see over time is as the obesity trajectory goes up, the diabetes trajectory follows it. And we'll see that over time and when we talk about it later in the slides, like some of the physiology, how that occurs and why we would expect that to happen. And obesity itself leads as a comorbid condition for multiple different conditions, including diabetes, but it also puts you at higher risk for heart disease, hypertension, osteoarthritis exacerbation and worsening, issues with PCOS, infertility, sleep apnea, gallstone disease, and some mood disorders. And so this is also another iceberg that we're dealing with here in the US. And so when we look at, well, what's the severity of that problem? This is the most recent data that they've looked at where 42% of the US population currently meets criteria for a diagnosis of obesity class 1 or higher. That's a BMI of 30 or higher. And if we continue on the current trajectory, it is postulated that we will get to about 50% of the population by 2030. 1 in 2 people will meet obesity criteria diagnosis. Okay, so 1 in 2. So it's huge problem in the United States and actually worldwide. So we're going to take a step back a second and then look at how does diabetes occur? What are the physiologic changes that happen in the diabetic state? Now this is an older slide, and the intent of this is to kind of tell you where we started to think about like, well, what causes these things to happen to have somebody have high sugar state and develop the diabetic state. And so this is what they call the ominous octet. And so there are 8 abnormalities that have been identified that contribute to issues with glucose control. And so what we start to see is things with the pancreas where you get increased glucagon secretion. That's a hormone that makes your sugar go up. And then you have defective insulin secretion. So that's the hormone that should make your sugar go down. There are impaired incretin effect, which is a fancy term for a whole group of hormones that the gut puts out that helps with glucose regulation, how you get sugar where you need it, how you tell the brain we're done, we've got enough gas in the tank, or we need gas in the tank. And that system is impaired in the diabetic state. And so there's some interplay between all of these hormonal systems that kind of drive some of these physiologic changes. We see changes in the fat. So the fat will have increased risk for pouring out fatty acids when it shouldn't. We have issues with insulin resistance, how insulin affects how the fat works. And so we see changes in the signaling system. And the fat actually is a highly endocrine organ. There's actually more than 600 identified signals that come from the fat that we're still trying to figure out all what they do. There are some that we do understand fairly well and some that we don't, that play a role in how the signaling determines like where you are from an energy perspective. Do you have enough gas? Do you not at this particular time for the organism to run? We know that when folks are diabetic, they have trouble with peripheral glucose uptake into the musculature, so your engines are impaired. So even though you're having all this fuel floating around, you can't get it in the engines where you need to burn it. About 60% of your body's glucose is burned in the skeletal muscle. So if you can't get it into the muscles, the burn rates are down, and so that you become another problem with the mismatch. People have issues with glucose preservation when you don't need to in folks with the kidneys. And so what happens is the kidneys should get rid of some extra sugar, but they don't in the diabetic state, and you actually preserve sugar back into the plasma as your filters work more than you should in the diabetic state, and so that predisposes folks to ongoing problems. We see problems with glucose production from the liver. So your liver has the ability to make glucose for you when you don't have it. Part of the challenge is that it keeps doing that when you really don't need to. And so that we have this problem where we're taking it in and making it at the same time. It's a duplication of services, and so it leads to some disruptions. We see changes in neurotransmitters in the brain. So we see changes in how your body perceives the signals of what's coming from the periphery into the brain to tell your brain, do I have enough gas in the tank? Do I not have enough gas in the tank? We also see changes in expenditure related to those signaling processes that are tied to this. And a lot of the initial, at this time back in the 2014, we were, and it's still going forward, a lot of the medications we use are to target certain parts of this octet to help you deal with those problems to make them a little bit better by manipulating the signaling process. So fast forward almost, we're getting close to 10 years now. 10 years now, we're now seeing that more and more abnormalities have been identified that are part of the diabetic process as to why we're developing these abnormalities. And so they've added 8 more to the list. And so now we've moved from the ominous octet to the sweetening 16. And so we now have 8 additional findings that have been tied to the development of the diabetic state for type 2 diabetes. And so I'll kind of go over those a little bit in brief. And so when they talk about catecholamines, think adrenaline. And so what happens in normal physiology is you should have a cycle of serotonin and dopamine that happens in the brain that helps you with signaling, relates to fuel. And then normally when you're in an insulin resistant state and you're having trouble with glucose processing because of problems with insulin signaling, your serotonin levels will go up, your dopamine levels will go down. And so what we find is in the early morning, because that dopamine drops, you get an adrenaline spike, and that causes glucagon release, which causes your sugar to spike, which is why people get what they call the dawn phenomenon. Okay, where they wake up and my sugars are really high. Why are my sugars really high? I haven't eaten anything. What's up with that? And so that's related to that physiology is the current postulation. We know that vitamin D plays a role, and so vitamin D has got a lot of different jobs and gets used in a lot of different areas, but they think that vitamin D may help you preserve beta cell function. Beta cells are the cells that produce your insulin, so you want your cells to last as long as possible so you can make your own insulin so you don't have to take it. And then secondarily, it also improves insulin sensitivity at tissues by increasing the insulin receptors on the tissues. And so what they did is there was some data that looked at one nurse's health study where they looked at individuals in regards to the development of type 2 diabetes, and they found that individuals in that study, that large health study, that were taking more than 800 international units of vitamin D plus calcium had a much better chance of not developing diabetes versus folks who had a lower intake of vitamin D of 400 international units or less, and to the point of if you were in the lower cohort of that group, you had about a 33% increased risk of developing type 2 diabetes. So we know that individuals who have issues, the renin-angiotensin system, and that's a fancy system that deals with cardiovascular function and blood pressure and blood flow, that there are not only that systemically, but certain organ systems can have issues there, and then we can see alterations in that it may affect blood flow to the pancreas, which may in fact function. We're going to talk about testosterone in guys here in a little bit. Melatonin abnormalities are related to the insulin-resistant state, and that contributes to why people have problems with upregulation in eating behavior, and we see more problems with weight and obesity in like night shift workers. So we see challenges in those departments. We do see that the kidneys actually have the ability to make some glucose. It's not as major of a deal as the liver, but that seems to be upregulated as well. It's back to that make it in and taking it in at the same time problem that we have with the liver that we talked about with the ominous octet. We'll touch base a little bit on SGLT1 co-transporters here in a bit on another slide. As we kind of move forward, and we'll also touch base on the gut microbiota and like how does your gut bacteria floral affect the system and how that functions. So this is to talk about testosterone production, and so we know that actually now not only does testosterone make a guy, it increases muscle mass and strength and libido and all those lovely things, it also improves insulin sensitivity. And so they did an Haynes study, which is a major study that was done, and they looked at guys who were in the bottom third of testosterone production, and those guys who were in that boat had about a fourfold increase of developing type 2 diabetes because of a testosterone deficiency. They find that testosterone helps us inhibit lipoprotein lipase as delimited on the screen, and basically that's a nice way of saying it keeps you from taking triglycerides up into the sick fat, which is the visceral adiposity. So you want your healthy fat to work, not your sick fat, and that helps decrease the size of those cells, therefore decreasing your risk for insulin resistance. When your testosterone levels are low, that's not inhibited, and so people will see increases in the insulin resistant state. And so conversely, if you're already insulin resistant or you're diabetic, you're going to have more issues with because of the feedback loops of having enough testosterone made from the testes to get an adequate level to get the effects of that hormone. And then the other thing for guys in particular is the fat mass has this aromatase enzyme, which has a nasty little habit of taking guys' tests and making it into estrogen. And so that's why I joke with guys in the office and I tell them, and they're like, this is why you're not watching football and you're watching Cupcake Wars now. So kind of looking at how these components play a role in the metabolism process. So when we look at the gut, and this is more in the small intestine, the proximal small intestine, SGLT1 is a receptor that allows for after carbohydrates are broken down in the gut, for upregulation and carrying glucose across the cell membranes and getting it into the tissues of the body. And so it's one of the major ways we absorb glucose from the gut into the tissues. And so what we find is that when people develop diabetes, there's an augmentation in the number of receptors you have in the gut for this type, and so we absorb more sugar than we should need to from the gut as part of that process. And so because of that, we're getting more sugar into the system, and then we have more sugar to deal with. And also at the same time, as we talked about earlier, GLP-1 is one of the signals that help tell your brain you're done eating. And so those are impaired, and so people roller coaster a little bit, and they're taking in more fuel than they need, they're not getting the shutdowns when they need, and they're more efficient in taking glucose in than they really should require. And so that becomes an ongoing cycle that becomes a problem for individuals. And when you talk about the gut itself, there's a lot of thought that we now have two genetic sets of code. Okay, we have the genetic code your mom and dad gave you, okay, and that you were born with, and then there's the genetic code that you get from your gut flora, and that through the process of how the gut microbiome works and how it interacts with your system through the gut, it impacts on the cellular functions at multiple levels in the human body, and it's an active area of research. And so what we find is when the gut microbiome is working normally, that we get proper digestion of dietary carbohydrates, we get short-chain fatty acids, and there's regulation of how glucose gets in across the lining of the small intestine and into the system, and then it's processed properly so that you get the right amount of fuel at the right time and you get the shutdowns when you're supposed to. Particularly things like Bacteroides and Firmicutes ratios, those are two species of bacteria that are common in the gut that they're seeing are important. Help maintain the mucus layer on the lining of the gut so stuff stays where it's supposed to. Okay, and so the challenge becomes when we have alterations in the gut microbiome, that mucus layer doesn't work as well, okay? And that we see there are changes in glucose uptake into the system. So glucose comes in much more easily and it's less regulated, so we get higher loads. We also get, because of those disruptions in the layers, bacteria get where they're not supposed to be, which causes an inflammatory response on the other side of the gut lining, which and then translates systemically to all kinds of inflammatory changes throughout the system that affects how the fat works, affects how insulin works, affects how the liver works, and then contributes to the glucose regulation process abnormalities that contribute to the diabetic state. And so this is that, and I know this is super complicated, and I'm trying to make something complicated easy, which it's tough to do. But the intent is to give you an idea of how many things can go wrong in the system that contribute to why people feel the way they feel, and why do their sugars do what they do. And so kind of targeting each of these as we try to treat people is important to help them move forward. Now, we're going to focus a little bit on insulin now in particular, since that's a big player in this and kind of helping people understand that and how that plays a role in weight in particular. So we're going to talk a little bit about the concept of insulin resistance. Again, I kind of alluded to that with the microbiome slide, that you get inflammatory change, that you get changes in insulin resistance. And the point is that in normal physiology, your insulin secretion should match your glucose uptake. So if you eat a piece of broccoli, you get a little bit of glucose from it. After you break it down, you should get this amount of insulin to put it away. You eat a cookie, a lot more glucose, a lot more insulin, okay? So the two should follow each other up and down based on what you're taking into the system, okay? So what happens in the insulin resistant state is that system doesn't work correctly. And so now instead you get this much glucose from your foodstuff, now you're needing this much insulin to handle it, and that has downstream ramifications on how the signaling works. And and that's what we're illustrating here, is that you should get an insulin signal. It should bind to the insulin receptor. It should turn on what they call the GLUT4 receptors, which is kind of the gateway for getting sugar into the cells. And then you should be able to take that in, and then that should dissociate, and you should be able to go about your day, go and do your next thing, okay? And you should be stabilizing your sugar. When I talk to patients in the office, I use the analogy, your body should run like a car. So if your car works right, you use just enough gas to fire the pistons so the car runs. You don't want to flood the engine, not get any gas in the engine. Those aren't good days. And it doesn't matter how fast you drive, you're using the same amount of gas each time to cycle the engine, okay? So if you think of glucose as your gas and your cells as your pistons, you want the right amount of glucose to feed your cells at any one time. That's the whole goal of this fancy system, okay? And so what should happen is you should be able to get that, load that fuel, put it away in the fat and muscle for storage with that insulin signal. As you burn what's available and your blood sugar drops, you should pull that stored fuel back out, replace what you just used, and so you can't maintain an even fuel source all the time, no matter what you're doing, okay? So when this system goes awry at multiple levels, people roller coaster through the day. So I loaded fuel, I ate this cookie, I got a glucose spike from it, I got the insulin spike to match, nothing happened. My pancreas said, that isn't a good idea. I'll put out more insulin. That's a good idea. Okay, so now I put out this much insulin instead of this much for the same job, bind up all these extra receptors. I got this sugar stored. Go me, okay? But now the insulin binds up the receptors. Now you've locked the gas tank while the engine's running. So the cells start to burn what's available. Your blood sugar drops. Brain's like, give me some gas from the gas tank. You get other signals that are dysregulated as well. So this is why we see dysregulation in glucagon. We also see dysregulation in ghrelin. We'll talk about what ghrelin does here in a little bit. And so people get hungry, and they've got to eat, and they chase fuel through the course of the day, and they get in the stacking phenomenon where they're taking in more fuel than they really require. And when they try to calorie restrict, they can't access Fort Knox because they're always in a storage state. And so their weight goes up over time, okay? So that's the concept. And then over time, what's gonna happen, and we'll show you this in a little bit more in later slides, is you burn out the cells that produce insulin. And you start to get to a point where you can't keep up with the loading process anymore. And so this is a kind of a constant roller coaster people get on, and it just gradually gets worse and worse and worse over time. And so that's what's being talked about here, is you get this inflammatory change, again, the microbiota changes in the gut, where you get inflammatory changes on the gut lining. That's what that is up at the top. And that inflammatory change causes certain changes from your immune system, like, hey, there's somebody here who shouldn't be here. And so we get an inflammatory change, which gets secretion of certain anti-inflammatory mediators. They're called interleukins. So think of just parts of a war of how you handle an infection. And that unfortunately, those alter how the fat works. and then we end up with problems with insulin resistance physiology, and they think that's what's related to that first schematic that we were talking about. The problem is that not just affects the fat. It affects the fat, it affects the muscle, it affects the liver, it affects the pancreas. And so people roller coaster through the day chasing fuel. You have the abnormalities in the insulin levels, so you're pounding out more insulin than you really should. You're also pounding out, because your sugars are dropping, you're pounding out more and more glucagon to try and bring your sugars back up. And the other key thing is glucagon stimulates ghrelin release, and ghrelin is your hunger hormone, okay? So you get hungry. So people get hungry all the time, and they're always chasing fuel. And then and because of those signaling process, they're always telling the brain, we're out of gas, we're out of gas, we're out of gas. We got to do something about this, okay? So that leads to an increase in weight. And so the intent here is to kind of talk about, and hopefully I've done this some justice, that hunger is a well-orchestrated event. That when we are hungry and we're eating, there's a series of signals we go through physiologically that you're supposed to have happen that tell your body what to do at that particular point in time. Okay, so this guy's staring at a sandwich saying, man, this looks good. So his hippocampus remembers, I like that sandwich. That's an awesome sandwich, okay? He's getting the visual cues that's setting that off. We tend to get, then we start to get issues with your Tarzan in your brain, which is your portion of the brain that deals with reward. You're like, yeah, I like that sandwich. That's a good time. And so our prefrontal cortex kicks in and says, okay, let's do it. Let's do it. Let's eat this sandwich, okay? So you start eating the sandwich and you start to get, your mouth salivates, your body's getting ready to break down that sandwich. You will get signals, anticipatory signals from the mouth to the microglia in the back of the mouth that fire signals to your brain. And your brain's like, that's fuel coming. So you get signals down via the vagus nerve to your gut. It says, fuel's coming, get ready. You're gonna have to store some stuff, okay? And so we get a spike in CCK initially. That's one of the initial signals. That gets your gallbladder working. And so you're producing some bile to break down the fat in that roast beef, okay? And then after that, you start to get signals from amylin to insulin as things get down into the gut. And those are getting you ready to store the fuel as it gets across the membranes, as the gut breaks things down, and you get a blood sugar spike. And you start to store that fuel. And then as that food bolus gets further down in the gut, you're going to produce things like GLP-1, PYY, and oxymodulin, which are hormones that help tell the brain, you're done. We've finished the eating process. So we've got the tanks full. We can shut it down, go do something else. I got something else to do with my time, okay? So when that gets altered, then chaos ensues, okay? And so that's really what this is trying to describe is, in the fasted state, if you're out of gas, you should be pulling fatty acids from the liver, from the fat to feed the liver to be able to make some glucose, and your triglycerides should go down, and you should get uptake of fatty acids into glycogen stores in the skeletal muscle, so you should be able to feel the engines and those sort of things. And then when you're in the fed state, you should be storing stuff in the fat, you should be storing stuff in the muscle, you should shut down glucose production from the liver because you don't need to make it and take it in if everything's working right. And then you're able to kind of move on from there. The problem is when you get into the diabetic state, that doesn't happen, okay? And so what we have is we have fatty acids still going out when we're feeding, just even though we've got fuel, we're making it and taking it in at the same time. We're not getting into the muscle the way we should. And so people end up in this high sugar state and they roller coaster through the course of the day trying to fix it. And as I've alluded to already, there's a progression of this over time. Okay, and so when folks start with the obese state or they start with the insulin resistant state and that contributes to the obese state, over time you get gradually increasing need to produce insulin from the beta cells in the pancreas. So you're always pounding the beta cells to produce more insulin because I got to store sugar. And then you get to a point where your cells can't keep up anymore. Okay, and so what you start to see is decline in the beta cell function, which is a fancy way of saying your pancreas got tired, okay, and we can't keep up with the sugar loads anymore, and the sugar is starting to rise, and so what you see is then your glucose starts to go up, and then we start to develop into the insulin resistant state, the pre-diabetic state to the diabetic state, and statistically that takes about 10 years from onset to kind of when you start on the insulin resistant state to moving to the diabetic state statistically. Now, some people are faster, some people are slower, but if you didn't make any changes, that's where it goes, okay? And so that's kind of the progression over time. So the challenge becomes also, there's another wrinkle. And so when people are like, okay, I get that, I'm going to change what I'm doing, all right, to try and affect how this signaling works. But the challenge, and say you're successful in losing weight. Okay, you implement some strategy to try and cut down your calorie intake. You're able to stabilize things. You're able to take maybe some meds that help with things a little bit. Why did I lose weight and got it back? So I did the whole 30. I did OptiFast. I did, whatever. You can put whatever diet you want in there. And you lost weight, okay? And then all of a sudden, a year later, you're sitting there and you're like, I'm back where I was. What's up with that? I didn't change anything. And this is the concept of what we call metabolic adaptation, or the set point. So this is a hypothalamic issue where your brain looks at the current fuel status based on the peripheral signaling. So as you're losing weight, you're getting signals from the periphery into the brain. It's telling the brain the tank's empty. And so as your body's being told that the tank's empty, your brain has a choice. It has to do something about it. It thinks you're in a starvation state. You got stuck in some field somewhere, you can't find anything to eat, okay? And so it turns the burn rates down and sends you on a forage to try and get the lost fuel back by turning up the tank empty, allowing the tank empty signals to kick in and turning down the tank full signals, so people get this adaptation response where they gradually return their weight to normal. Now, that's one of the challenges people have when they're trying to lose weight. And they have to deal with the set point by some mechanism, whether it's your diet, your exercise, your pharmacology, surgery, all of them focus on that particular problem. You have to deal with that in some form to be successful long term. And and here to that one side there, that's the Saxenda, and I'm not pushing Saxenda specifically, it's just meant as an illustration that medication augments GLP-1, that tank full signal in the brain, so it makes your tank full signals louder than your tank empty, so that as your body's moving forward, your brain's got a choice, like, well, you say the sky's falling, and this guy says everything's cool, and he's louder than you, so I'm listening to him. And it's like, all right, burn whatever you want, I don't care. And so the fat mass moves down as you're able to move back towards a normal gas tank size, okay, which is what the goal is of weight loss. And so we kind of talked a little bit about the metabolic brain, and I've touched a little bit on this. It's just that obesity is a chronic multifactorial disease. That there are multiple different factors genetically that you bring to the table, early life events, imprinted behaviors, clean your plate. Those of you who grew up in the Clean Plate Club, okay, so you know what I'm talking about. And how that affects energy in, energy out. And then the brain has to interpret all that signaling from the periphery as well as centrally on what you do. And essentially in weight, we have like 3 brains. Okay, we're just talking about the metabolic brain today because I don't have time enough to talk about the other 2. But you have your metabolic brain, which is kind of glucose regulation, energy in, energy out, how you decide what you're going to have available for the system, what the status of the system is at that particular time, versus emotional eating. That's like when I want it. We talked about that a little bit with dopamine, And then volitional or cognitive eating behavior is like, I'm going to go get it, and it's impulsive behaviors. So when you talk about central processing in the brain, there are two centers in the hypothalamus. Basically, your tank empty signals and your tank full signals. Okay, and what we have are all those signals we were talking about earlier are brought to the brain, and so the brain can interpret where your current status is. Are you in a tank empty state or are you in a tank full state? And so those signals either turn on the eating mechanisms, okay, and turn down burn, essentially, or you turn down eating and turn up burn, okay? So your system's always feed or don't feed, burn or don't burn, all the time, 24/7, 365, okay? And so depending on what's going on with this signaling process that's coming in from the periphery, the brain's gonna react accordingly, okay? So if you have alterations in these signals, then you're gonna have alterations in what the brain does, okay, is what it amounts to, okay? So if you have problems with leptin sensitivity and insulin sensitivity, and we think that most people who are insulin resistant are also leptin resistant. Leptin's the signal that comes from the fat that tells the brain the tank's full. And so because of that, you're going to be in a tank empty signal predominant situation all the time, okay? Versus let's say you have gastric bypass, okay, or a sleeve where we take your ghrelin levels and we drop them out. And I'll talk about that in a few minutes. But basically now you're going to be more in a tank full state than a tank empty state, okay? So depending on how that signaling is working will drive what your brain does, okay? And so these are the centers that are involved with that. So you have the ventromedial hypothalamus, which is the VMN on this, and the arcuate nucleus are kind of where your tank full signals lie. So if you trash those areas, people get rapid obesity. That's where your leptin and other receptors sit for GLP-1. There is access to that. That's a real porous area at the median eminence, so it has access to the blood. And so your signals in the blood that are going out in the periphery get interpreted there in the hypothalamus, okay? Also can get signals from the vagus nerve that binds in the periphery and signals up through the vagus nerve into the brainstem, and then that fires over to your hypothalamus and tells the brain what's going on between those two methods, okay? And then we also see in the lateral hypothalamus, that's where your hunger hormones, hunger neurons live, and that's where your ghrelin's gonna bind and help you when you gotta eat. So I've talked a little bit about, and hopefully that's clear, that obesity is a chronic, progressive, relapsing, treatable disease. There's not a cure. You know, a lot of folks feel there's a cure. You're like, I'm going to do X and I'm going to be good forever. And the answer is no. Okay. And you have to constantly manage the disease, but it's manageable. It's manageable. It just depends on the situation for a particular individual. I would say I would update this definition. This is from 2021, but I would say the newer evidence suggests this is a neuroendocrine behavioral disease, that there's a lot of hormonal signaling pieces that play a role, that promotes adipose tissue dysfunction, abnormal fat mass forces that lead to adverse metabolic, biochemical, and psychosocial health consequences. And we know it's important to treat this because it helps with the diabetic state, it helps with the pre-diabetic state. So if you can get weight loss by a method, you can work on the metabolic syndrome. You can improve diabetes. You can improve pre-diabetes, and we can get those systems to basically go into remission in a lot of cases. So when we talk about treatment, there's 4 main pillars that we work on. We work on nutrition. How am I loading fuel? What type of fuel am I loading? And does it make sense with my physiology or not at this particular time? Physical activity. What am I able to do to help with expenditure so that I can get things moving, so I can increase the metabolic rate as I'm kind of moving forward? What behaviors do I do that contribute to how these things happen? Is there ways for me to change my behavior that change both my nutrition and my physical activity? And then if we need to, consider medications to affect how the physiology works, okay, so that the signaling works more correctly. And so people always ask, well, what's the best diet? And the answer is all of them are the best diet and none of them are the best diet. And so, the take-home point is the diet needs to fit the individual and the physiology of that particular individual at that time. So what you're trying to do is create a calorie restriction that your body will accept and change how the physiology works. Okay, can you move to where your tank full signals are predominant versus your tank empty through dietary manipulation? Oh, that's what you're trying to achieve. Okay, so if you have insulin resistance, pre-diabetes, diabetes, you're going to, one of the hallmarks of that is try to decrease insulin secretion. You do not want to make any more insulin than you have to. You have to make some. We can't do it without it, but you want to make as little as possible because you're trying not to store fuel. You're trying to use what you have. Okay, so you're trying to change how the signaling works. So things like higher protein, lower carbohydrate diets or keto diets could be considered. You have to take that in context of what other things people have that they're bringing to the table, what other conditions they have. If you have, like, say, heart disease, you may want to do more of a Mediterranean style diet. If you have cancer or an inflammatory disease, you might look at more at a plant-based diet to decrease the inflammatory process. So it really depends on the individual that helps them kind of manipulate how the signaling works. We do focus a lot on protein. You hear a lot about it in the news, and the main reason is protein suppresses ghrelin the most out of the macros. And so between carbohydrates, protein, fat, protein does the best job of suppressing ghrelin. And so we use that to help people deal with that tank empty, tank full scenario. Okay, how much protein you use, what the individual requires, how you load that, whether it's plant-based, meat-based, other forms, will really depend on the individual. Okay, and it has to be individualized therapy. And so same thing with exercise. We normally, when we write an exercise prescription, you need to have, like, what kind of exercise you're going to do, like mode, how often, duration, intensity, progression, so people kind of have a sense of what they should be doing to go forward to help with metabolic rate. You're going to need to look at specifically what are you capable of. Do you have orthopedic, cardiovascular, pulmonary issues that make exercise difficult? What kind of equipment do you have? What kind of access, both equipment or actually memberships or other things. I have patients who don't have any of that, but they go out and cut wood all the time, and I'm like, okay, that's strength training, that's fine. So the point is, it depends on what works for you to help you hit those modalities. And what we know is that the lean mass acquisition helps with set point. Better shape your muscle, the more calories you burn. And so when the hypothalamus is trying to turn down the burn rates when you're losing weight, the muscle's yelling at the brain saying, hey, I'm working here, stop it. Okay, and so that's kind of the take-home point for that. When we talk about the meds, I'm not going to get into the meds today, but it's just to kind of make a point that the meds need to fit the person and what you're trying to treat. So if you're treating like insulin resistance, diabetes, you're going to focus more on the meds that work in those arenas. You see a lot in the news about the GLP-1 class, and that's largely because the GLP-1 class, like the meds like Wegovy, Saxenda, tirzepatide, if you're talking on the diabetic side, Trulicity, Ozempic, those type of meds, all augment GLP-1 signaling so that your tank full signals are louder than your tank empty, and you calorie restrict the individual, and you stabilize insulin resistance, so you don't have as much sugar yo-yo. And so those kind of how those things work, and that's why people see improved results. Some of the central tools are sometimes used to add to that to help stabilize the brain, to kind of get those central signaling where your tank full signals are louder than your tank empty, by manipulating the hypothalamus directly and using that in conjunction with some of the stability through glucose regulation abnormality, changes by dietary intake, and so forth, okay? So these are the FDA-approved weight loss drugs that are on the market right now. There are more in the pipeline. You're going to see more and more in this incretin path, those hormones that come from the gut, as we kind of understand those a little bit more and how they manipulate glucose and how your body handles fuel, and then how it changes the signaling process. And so there's a pyramid that we follow as we treat people to help them get better, in regards to, starting with diet and exercise, behavior. If we're not getting where we need to with those changes to change the physiology, we talk about where we can manipulate things pharmacologically to make the system work better. And then from there, we can talk about combinations of those therapies with surgery, and how surgery can add to treatment options. And just a quick nod to the surgeons. And so the intent of surgery is to change the metabolic environment in the body by surgical means, okay? And so again, like I alluded to earlier, you got to make your tank full signals louder than your tank empty by some method. The surgeries are meant to do that. So if you do a sleeve on someone, as an example, and you take the greater curvature of the stomach off and throw it away, 80% of your ghrelin-producing cells are in the antrum of the stomach, the top of the stomach. So if you cut that out and you throw it away, you've now manipulated the signaling in a way where your tank full signals are louder than your tank empty by default. Okay. If you do a bypass on someone, again, you're not getting stimulation of those ghrelin cells because that limb gets moved over out of the way. It's not getting food. It's not getting stimulation as much. And then also when you bypass to the lower end of the intestine, it augments GLP-1 production. And so you get more tank full signal into the brain. So again, your tank full signal is now outpacing your tank empty signal. And that's why we get weight loss. So I'm going to switch gears here a little bit. We're going to talk more about components of impressions of weight bias and weight discrimination. And so I use this slide as what's your first impression when you look at this? What comes to mind? What's your impulsive response, reflex? A lot of people will say that, well, that person on the left must work out a lot. She must eat salads, that sort of thing. And the person on the right must eat a lot of fast food, not do much, that sort of thing. And so the take-home point of that is that's not always what it is. Okay, and so you may have that thin person who actually has poor dietary habits, never eats well. We all have those friends, and yet the signaling doesn't change because of their makeup. And you have other individuals who have excellent diets. They really push hard on making sure they're eating the right things in the right portions at the right time, exercising regularly, and still struggle with their weight because of the physiologic abnormalities. And so we get into these situations where there's a lot of finger pointing. People pointing fingers at people and people pointing fingers at themselves. And so Scott Kahan, who's a hotshot out of Washington, D.C., did a major study that was published in the Journal of Obesity, looking at perceptions and weight bias, and that approximately 60% of individuals who struggle with weight blame themselves. That they're like, this is my fault. I did this. Yeah, I could have made better choices. And when I'm not losing weight, it must be something I'm doing wrong. I gotta buckle down. I gotta do what's better to get to where I want to be. And it may not necessarily be true if you think about the physiology we just went over. Okay. And so that becomes a challenge, and then it predisposes folks to discriminatory behavior. And so researchers have found that about 59% of individuals who struggle with obesity have reported weight discrimination. 42% of those individuals have had unfair treatment in hospital settings because of their size. We have seen that individuals have been denied employment opportunities because of their weight. They've been belittled or mocked because of their weight. They've been harassed at work. They've received poor customer service. They've had poor treatment from doctors and other providers due to their weight, and excluded from family or friend events because of their weight. And so this is an ongoing, the last bastion of bigotry in the United States that's considered acceptable. And so that has downstream effects for the individuals involved. So weight stigma causes folks from a mental health well-being, lower self-esteem. We see higher rates of depression. We see poor body image, more anxiety. We see an increase in use of substances to try and help them cope with the stressors. We see actual physical changes. We actually will see increases in inflammatory change for individuals. So they have more C-reactive protein. That's an inflammatory marker. There's more cortisol production, which drives more weight gain through the fight or flight systems. We see issues with blood pressure elevations, oxidative stress on the cardiovascular system, and increased A1Cs, making it harder to control their sugars because of that event or events. And so this is a recent study where they looked at over 2,200 Americans looking at weight discrimination, and we're trying to kind of measure what happens for those individuals. And they found more than 60% of the participants in the study had weight discrimination events that at least one occurrence of employment-based discrimination where they were not hired for a job just based on their weight, not based on what they were capable of doing. On average, a person's chances of being discriminated against because of their weight gets higher as their weight increases. So 10% of females in the overweight status describe some weight discrimination. 20% of women with the disease of obesity had that happen, and 45% of women who have struggled with obesity grade 3 or higher, so which considered more severe cases, have reported weight discrimination. Men tend to have a little bit lower frequency of those events, 3% of overweight, 6% of folks struggling with obesity, and 28% of men struggling with severe obesity having some discriminatory behavior against them. And the intent here is to kind of look at that discriminatory behavior actually affects the outcomes. And so it becomes harder for those folks to get healthier, because what happens with the discriminatory component is that perceived weight discrimination increases about 60% higher odds ratio of being inactive, as an example. And so we find that people have worse outcomes. And actually, when you look at the doctor literature, if you try and take the tough love approach in the doctor world and helping people with their weight, they actually do worse. And so the intent here is that we need to be mindful of how we approach this disease process and treat it as a disease rather than as character flaws for individuals. And so this is just a component about just how we handle patients in the office in regards to asking permission to discuss weight with a patient, make sure we're assessing their health status, looking at causes for weight gain. But I use this as kind of a nod to try to think about that we should, as individuals, I would advocate that we need to treat this as a disease, not as a character flaw, that we talk to people about this respectfully, that we start to look at that we can treat this as any other disease we face here in the United States. Is becoming a larger and larger problem in the United States based on prevalence, and we're going to have to change and how we do this. Right now, a lot of times, weight treatments are not covered by Medicare, and there's an act in Congress called TROA, which we're trying to Treat and Reduce Obesity Act. And so I advocate people, talk to their congressman if they're into that sort of thing, to try and push to get equity for treatment. So this is no different than any other disease you could treat, and it shouldn't matter whether you have the disease of obesity, you have the disease of heart disease, disease of hypertension. You should get treatment options either way, and it shouldn't be an excluded benefit for you. Okay, and so I believe there are some, if you're interested in that sort of thing, there'll be some out in the health fair. There are some sheets about how you can contact your congressman to see about getting equity of treatment, because a lot of the treatments we have are very profound nowadays, but access for people is limited. And some of that has to do with coverage and just the cost prohibitive nature of some of these treatments that are life-changing for a lot of people. And so that's why I work on advocacy boards and try and work with people on trying to get them access to their tools to help them get to a healthier state. And that's the end of my chit-chat, so I hope that was helpful, and I thank you for your time.